نشوف أول حالة. أوكي.
Capacious canal,
Sorry.
dilated spinal canal, capacious.
Capacious spinal canal.
نعم.
Yes.
Intramedullary lesion at cervical spine behind C2.
Cervical spine. C2.
No.
There is a lesion inside the spinal cord. Yes.
Yes, sister. Intramedullary lesion.
Yes, and there is a lesion in the spinal cord, and this is T2 weighted image, and the lesion is of low signal surrounded by a rim of bright signal. And what do you think? No answer. No suggestion. Okay, then anyone will give the answer. All right, if you look carefully to the CT scan, and you can see that the spinal canal is capacious, as you mentioned, but if you look carefully here, then you can see that the odontoid is fractured. And this is type 1 fracture of the odontoid, which is non-displaced with consequent intermedullary hemorrhage. And the hemorrhage, if it is acute, it will appear of intermediate signal in the T1 and of dark signal in the T2. The rim surrounding the hematoma is a perifocal edema. Then what I want from this case is to remind you that you should, in every case of the cervical spine, whether by CT or by MRI, you should look carefully for the region of the odontoid. This region is frequently missed during the evaluation of the spine because we usually concentrate on the disc bulge herniation and the intramedullary abnormalities. Also, this area is missed because it is not included in the axial images. Then the final answer here is a fracture of the odontoid process and intramedullary acute hematoma. Next case.
Spondylodiscitis of L4 over L5.
Okay. Then,
with bone marrow edema type 1.
Yes, and the last answer is right, and this is type 1 bone marrow edema of the vertebral end plates. You should carefully discriminate between this type 1 degenerative bone marrow edema and the disc space infection or discitis. Or for the discitis, you should see very bright signal in the disc space, as well as you should see some erosive changes in the opposing vertebral end plates. But if the signal is very faint like this and the end plate is intact, then you should think of the type 1 degenerative bone marrow edema. And you know, we have three types of degenerative bone marrow changes. Type 1 is edema, type 2 is fat, type 3 is bone sclerosis. And here is an example of spondylodiscitis at this level. Probably this is L2-3. Then you can see clearly that the disc is very bright, and the end plate is irregular and interrupted in some areas, together with more extensive edema, not only in the vertebral end plates, but it involves most of the vertebral body. Next case.
Discrimination L4 L5
L4
Left
L5
side.
discrimination.
Yes. L45 discrimination, right or left?
Left.
to the left.
Central.
No.
Central to the right.
Yes, it's to the right. And if you look carefully, that this foramen is more or less patent, but this foramen is almost totally obliterated. The cecal sac is markedly compressed. And this is, of course, a disc herniation even without the axial images, because the disc is extending above the vertebral end plate, above and also below the vertebral end plate below. And in the sagittal image, you can see that the herniating disc is reaching the bone at the back of the spinal canal.
Can we say right paracentral?
Yes, and actually, if you look carefully here, this foramen is obliterated, and this is a little bit is relatively preserved. Then this disc is towards the right side. Actually, this is the history.
Sacroiliated
Yes, what do you say?
Ankylosing spondylitis.
Ankylosing spondylitis, you said?
Yes.
Okay. This history is almost a classic for the recent topic, which is known as axial spondyloarthropathy, and I hope that you have heard this lecture. It is included in the recently included in the curriculum, and this topic is now well known in rheumatology, and is divided actually in two main issues. What's known as radiographic axial spondyloarthropathy and the non-radiographic spondyloarthropathy. By radiographic and non-radiographic, they mean that if the sacroiliac joints are affected in the plain film, then this is known as radiographic spondyloarthropathy. But if you see that the sacroiliac joints are normal in the plain film, but they showed some abnormalities in MRI, especially the bone marrow edema, then you know that this is the non-radiographic axial spondyloarthropathy. The history should be like this: low back pain, which is insidious, and there is some morning stiffness, and this will improve by physical activity. And sometimes there is the night pain, alternating buttock pain, and the patient should not have a history of inflammatory bowel disease or psoriasis or uveitis, because these will support the diagnosis of ankylosing spondylitis. Then also the patient will have human leukocytic antigen B27 positive with no family history of rheumatic disease. If you can spot these criteria in a patient who is below the age of 45, then you may say that the patient has axial spondyloarthropathy. If the sacroiliac joints are normal in the plain film, this is non-radiographic. If they are pathologic, like you see here, this is called radiographic axial spondyloarthritis. And here you see the changes in the plain film and the changes in the MRI. And the changes should be in the form of bone marrow edema. I mean, low signal in the T1 and high signal in the STER images. Then the patient had the typical clinical presentation with HLA-B27 positive, and then you call this the radiographic spondyloarthropathy because the lesion is seen in the plain film as well as in MRI. Then why they are interested in this classification? Because there are new drugs that are known as biologic drugs, and they are very expensive, and they have some let us say good results in preventing the progression of ankylosing spondylitis to the final stage of disease and so on. Okay, then this is the next case.
Transverse myelitis.
Yes, do you see the history? The patient had systemic lupus erythematosus and developed acute paraparesis with sphincteric dysfunction. And the MRI showed the longitudinal segment of abnormal signal and the T2 weighted images affecting the whole cervical spinal cord as well as the dorsal spinal cord. And actually, if you see some abnormalities in the cord in a patient with systemic lupus erythematosus, you call this lupus myelitis. And you know, of course, that lupus myelitis are the sequelae of vascular compromise to the cord, and it will appear in the form of longitudinal patches of abnormal signal. Then, if you see similar lesions in the brain in the patient with systemic lupus, then you call this lupus encephalopathy. In the spine, you call this lupus myelitis. Next case.
Schwannoma.
Yes, and this is a classic appearance of intradural schwannoma. This arrow points to another smaller schwannoma distal to the big one. And the classic appearance of schwannoma is an oval-shaped lesion, which is usually heterogeneously enhanced due to the presence of internal cystic changes. And this is the differential diagnosis of intradural lesions. You know that the most two common lesions intradural are the meningioma and the neurofibroma, and also the schwannoma. Sometimes you got leptomeningeal metastasis if the patient is known to have a primary malignancy, and if the lesion is attached to the conus, or maybe you may think of myxopapillary ependymoma and also paraganglioma. Then for the meningioma in particular, you may see this sign, which is known as Jenko leaf sign, and this is the leaf itself. Then the intradural lesions which are non-neoplastic are the lipoma, dermoid, epidermoid, arachnoid, neuroenteric, and of course intradural disc herniation. Next case.
Caudal regression syndrome.
Yes, and this is caudal regression syndrome because of the partial agenesis of the sacrum and the blunted edge of the conus. In the caudal regression syndrome, this is the incidence, and these are some of the associated findings like imperforate anus, renal and pulmonary aplasia or hypoplasia. In the plain film, if the sacrum is absent, you may got fusion of the iliac bones across the midline, but sometimes you got some remnants of the sacrum and the characteristic appearance of the cut or the blunted edge of the cones. And this film is frequent in the exams. You should look carefully for the presence of the sacrum. And here you do not see any sacral segments. Instead, you got only the spine terminating at L5. And this is the difference between the pointing end of the conus, normal pointing end, and the blunted edge of the conus in caudal regression syndrome. And here is the normal appearance of the sacrum, and here you can only identify two sacral pieces. And you know that regression above D10 is incompatible with life, but regression can extend up to D11 vertebral body. And here you see the fusion of the iliac bones across the midline, and this is approaching total fusion. Next case.
Metastasis.
Yes, this patient with colorectal cancer and peritoneal carcinomatosis. She presents with dorsal pain, progressive paraparesis, and impaired sensibility up to the dorsal level. Then you can see that this vertebral body is partially collapsed and it shows abnormal signal. And if you inject contrast material, you got some enhancement. But what is very important in this particular issue is the presence of associated soft tissue components, either inside the spinal canal or in the prevertebral region. This will support the diagnosis of metastatic deposits, because you know that a patient with primary malignancy may have osteoporotic fracture of the vertebra, and the fracture will show abnormal signal. It will show contrast enhancement, and this is very important. Bone marrow edema of whatever etiology will enhance with contrast material. Then the only differentiating point between the fracture like this one and the metastatic pathological fracture is the presence of extraosseous enhancing soft tissue component. This is very important because many times I see in the clinical practice some cases like this. This is T1 and this is T2. Then they inject the patient with contrast material and the vertebra will enhance. Then they said that if the vertebra is enhanced, this means that it is involved by malignancy, and they send the patient for biopsy. And this is absolutely wrong. Bone marrow edema of whatever etiology will enhance with contrast material.
Dr. Mamdouh, if you please bring the last picture before it, the picture before it.
Okay.
D12, is it another metastasis or it is a small node?
No, yes, this is another metastatic deposit here in the vertebral body.
Thank you.
Then next case.
Spinal canal stenosis.
Spinal canal stenosis.
Discitis.
Discitis also. 5 D12 على
L1.
Yes, and this is
في
spondylolischitis.
which fracture دكتور؟
No, here
D12 which fracture دكتور لولا؟
This is D12
12
and
نعم.
this is L1. It's eroded by the inflammatory material, and the disk space is very bright. There is also some instability at this level with subluxation posteriorly of the D12 vertebral body. And in the axial image, you can see an inflammatory granulation tissue alongside with the vertebra. Then one may ask how to differentiate this lesion with paravertebral soft tissue shadow. If you inject contrast, it will enhance from metastasis. You know very well that metastases do not involve the disc, and the metastatic deposits will affect the vertebrae without involvement of the disc. So the differentiation between inflammation and the metastasis is easy, but the differentiation between metastasis and the collapsed vertebra secondary to trauma is sometimes difficult.
meningioma.
Yes, and you know that the recent name of meningioma is a solitary fibrous
Solitary
tumor.
fibrous.
And this is a solitary fibrous tumor or an intradural meningioma showing the classic appearance with homogeneous enhancement and smooth margin. Next case.
Lipoma.
Yes,
Yes.
and this is
Lipoma.
yes, this is lipoma. In spite of the history mentioned that there is this scan is for assessment because of trauma, but the brightness of the lesion in the subdural space and uh, similarity to the subcutaneous fat means that this is an intradural lipoma. The next case.
CSF collection.
What do you mean by
I did
collection?
it.
Sorry?
I did it.
Very good. Yes, this is hydatid disease of the spine. And you remember I mentioned many times that the diagnosis of hydatid depends on the detection of a vertebral cystic lesion associated with intraspinal or paravertebral multiple cystic lesions. And this is the case here, and you see involvement of L5 and multiple intradural cystic lesions with scalloping of the vertebra, meaning that this lesion is long-standing and the diagnosis of hydatid is very good diagnosis. Next case.
Lipomeningeal.
Libo,
Like,
now we have two lesions here which will show fat related to the spinal dystrophy. We have the lipomeningomyelocele and the lipomyelocele. Then what do you think which one of two?
Meningomyelocele.
Okay. You mean lipomeningomyelocele. You mean that?
Yes, yes.
Okay.
Yes, yes.
What
Lipomeningomyelocele.
is the difference between lipomyelocele and lipomeningomyelocele? In lipomyelocele, the lipoma is attached to the cord inside the spinal canal. In case of lipomeningomyelocele, the cord is attached to the lipoma outside the spinal canal. So, if you see that the lipoma inside the spinal canal is continuous with the lipoma in the subcutaneous space, and this is lipomyelocele. meningomyelocele or lipomyelocele. Then you see the site of attachment of the fat to the cord. If it is inside the spinal canal, this is lipomyelocele. If it is outside the spinal canal, meaning that the cord is coming like this and is attached to the lipoma here, and this is lipomyelocele. Then this is a lipomyelocele where the fat in the subcutaneous space is continuous with the fat inside the spinal canal, and the site of attachment of the cord to the fat is inside the spinal canal. Then another case, you should see that this fat inside the spinal canal is continuous with the fat in the subcutaneous space. If not, if the fat inside the spinal canal is not attached to the fat in the subcutaneous space, this is intradural lipoma. And you can got a tethered cord with intradural lipoma, or tethered cord with lipomyelocele, or tethered cord with lipomeningomyelocele. Then, and this is another example, you see that the fat outside the spinal canal is continuous with the fat inside the spinal canal, and the attachment of the cord to the fat is inside the spinal canal. Then the diagnosis is lipomyelocele. Next case.
Multiple secondaries.
Yes.
Patient.
Yes, and this is a simple diagnosis, of course. And you remember, for the diagnosis of metastasis, you do not usually need to inject contrast material, because you can see the lesions very well in the T1 weighted image. And if there is an extraosseous soft tissue component, whether in the paravertebral space or inside the spinal canal, you can see it very easily. So the need for injection of contrast material in MRI for evaluation of the metastasis actually is not an issue, in my opinion, of course. Then in the early days of the plain films, we used to see these films in the exam, and you can see that what is known as the pedicle sign. If you look carefully here, you may see the pedicle on either side, but here you can see the pedicle, and on the opposite side, you see that the pedicle is effaced and is replaced by this tumefaction. Then we used to diagnose this as spinal deposit. And this is another example. You see the pedicle here is not present, but it's okay here. And these are two pedicles intact. And they may resemble this to the winking oil sign like this. I don't know, but it was known as the pedicle sign. Metastasis can be osteolytic and can be osteosclerotic. Metastases are usually associated with extraosseous soft tissue component that can extend inside the spinal canal, compressing the ceca, or outside the spinal canal, forming a paravertebral mass. And here you see the metastatic deposits are very well appreciated in the T1 weighted image, and they are usually less appreciated in the T2 weighted image because the signal of the lesion and the signal of the fat in the T2 weighted image are almost near to each other. And this is what supports my opinion regarding the contrast material. This is T1 weighted image, and this is T2, and this is T1 post contrast. Actually, you see metastatic deposits very good in the T1 weighted image, and you cannot see the deposits in the T2 nor in the post contrast image, because metastasis will enhance and became somewhat bright approaching the signal of the bone marrow fat. Next case.
Transverse myelitis.
Okay, the history is a diver with decompression sickness. Transverse myelitis actually is not a diagnosis, it is a descriptive term of an abnormal signal within the substance of the spinal cord. But in this history in particular, you know that there is what is known as decompression sickness, and this will result in some embolization of the nitrogen gas in the venous system, and this will impede the blood flow from the cord, and this will result in cord edema, and sometimes if it persists for some time it may lead to cord infarction. This is known as spinal cord decompression sickness, and this decompression sickness, according to the literature, is common in the dorsal region, where this part of the vertebrae is not mobile, similar to the cervical or the lumbar spine. Then they assume that the lesions are secondary to bubble embolization of the epidural venous system, and this will result in impedance of the vascular supply of the cord. It will result in motor weakness, sensory impairment, pain, bladder and bowel incontinence, and this is known as spinal cord decompression sickness. The possibility of this decompression sickness is high in patients with spinal canal stenosis, if the fitness of the diver is not that good, in obese patients, in those who are taking alcohol, and also the temperature of the water and the workload and the equipments also can affect this, the occurrence of this decompression sickness. Sometimes, if the patient is managed correctly, then you got reversibility of the lesion. And here you can see that there is extensive abnormality in the substance of the cord, which is not showing diffusion restriction, and it resolves after that with complete regression of the lesion and normal appearance of the spinal cord. So they call this ischemic-like lesion. It is not ischemic because of the absence of diffusion restriction and because of the regression. Next case.
Spondylolisthesis and spinal cord compression, T45.
Yes, there is no history of trauma.
So it is metastasis.
Yes, and this is once more, I emphasize this point. If you look carefully here and you see that there is an abnormal soft tissue which is surrounding the site of spondylolisthesis. This is grade 4 spondylolisthesis with significant compression of the cord, secondary to the presence of this abnormal soft tissue, which represents metastatic deposit that has resulted in this type of spondylolisthesis, and it called this pathological fracture dislocation at D4, D5 level.
Meningioma.
Okay, Then this is the classic appearance once more of a meningioma with homogeneous enhancement. And I repeat once more the differential diagnosis of neoplastic intradural lesions, meningioma, neurofibroma, schwannoma, leptomeningeal drop, metastasis, myxopapillary ependymoma, and paraganglioma. Next case.
Pseudomeningomyelocele.
No, pseudomeningocele only. And this is post-operative spine where you got evidence of laminectomy, and at the operative site you got collection of CSF, and this is known as pseudomeningocele, and it results if during surgery there is a dural tear that has resulted in some leakage of CSF to form this collection. Sometimes this collection may be secondary infected and may result in an abscess.
Arachnoiditis.
Yes, and this is
Sac.
typical appearance of arachnoiditis. You got adhesion of the lymph roots together to each other, and in this area you got absence of any nerve roots in the cecal sac, which is known as the empty cecal sac sign, and both signs are good for arachnoiditis. Arachnoiditis means inflammation of the arachnoid membrane resulting in inflammatory exudate, which will result in adhesion between the nerve roots to form a cord-like structure inside the cecal sac, or the nerve roots may adhere to the inner wall of the cecal sac, resulting in the second sign, which is known as empty cecal sac sign. This is the normal appearance of the nerve roots while the patient is lying on his back. But in this example, you got a clumping or adhesion of the nerve roots together, and this is a good sign of arachnoiditis. Next case.
Like, no. Y-shaped lipoma.
Ligamentum flavum hypertrophy and calcification.
No.
Secondary spinal canal stenosis.
Okay.
Acquired
You
spinal
mean
canal
that
stenosis.
these are the ligamenta flava? They are bright. Ligamenta flava should be black. Okay.
It's fat.
This is fat. Yes. And whenever you got excess fat inside the spinal canal, this is known as epidural lipomatosis. Epidural lipomatosis is an incidental finding and is usually asymptomatic. And if you it's very common actually in the lumbar spine where you got excess fat around the cecal sac, and this will result that the cecal sac will be compressed from all sides, resulting in this very specific Y-shaped configuration of the cecal sac. What are the causes of epidural lipomatosis? Most commonly is this is due to obesity. Sometimes it is idiopathic in patients with Cushing syndrome, and the long-term use of steroids, like in asthmatic patients, Sherman disease, or following the spinal surgery. Next case.
Secondary metastasis.
Where?
Intramedullary.
Yes,
Intradural.
and
3.
L2, L2.
La
in
L3.
the vertebrae, yes. And there are what I want you to notice is this one. And sometimes you got an intramedullary lesion, and without the history of breast cancer, if you see multiple other lesions in the vertebral bodies impressive of deposits, then you should think that this lesion is also a metastatic deposit. Next case.
Granulation or caudal migration?
What's the
Yeah.
operative?
Okay. And this is a sequestrated disk. Actually, there are new let's say new suggestions that if you see an appearance like this, you should consider that this is also a disk fragment, not a granulation tissue. And the frequency of disk fragment like this compared to the granulation tissue is very high for sequestrated disk fragment, and they simulate this by what's known as the double fragment sign. And I look in the literature for the meaning of double fragment sign, and I found this image which can correlate with what you see here. And you see the disk, and you see another part where there is some separator or some line in between, and this is known as the double fragment sign, which is diagnostic of sequestration. Then if you see like in a disk like this, and you see caudal migration and sequestration, then this is what you can see here, the double fragment sign, but it's not that apparent in this particular disk. And you may say that this is herniation, and look for the axial image to see the whether the disk is to the right or to the left. Next case.
Ependymoma.
Yes, and this is ependymoma of the phylum terminal. It is one of the 5 possibilities of intradural lesions. Next case.
Lipomyelocele.
Yes,
Yes.
and this is lipomyelocele because the fat in the subcutaneous space is continuous with the fat inside the spinal canal, and the fat inside the spinal canal is attached to the cord inside the spinal canal. Next case.
OPLL.
OPL,
And yes,
ossification of the posterior longitudinal ligament.
Pacific
This is,
anterior كمان
yes,
and the
and
seat, yes.
A ossification, OALL. But I would like you to know that whenever ossification is extensive like this, sometimes it develops bone marrow inside the ossified ligament. Then you may see some fat inside the ossified ligament in both T1 and T2 weighted images, and this will not change the diagnosis of ossification of the posterior longitudinal ligament. There are many types for the ligament to ossify, and a lot of things are mentioned in the literature for this, but don't bother yourself by the types. And it's very important is to diagnose the lesion. But because of the abnormality of this particular type, I will show you an example of this. But here you can see the ossification of the posterior longitudinal ligament as well as the anterior longitudinal ligament in the plain film, the CT scan, and MRI. Of course, the best is the CT scan for demonstration of the lesion. This, what I wanted you to see, is the abnormal appearance of the ossified ligament. This is not a disc herniation or a calcified disc herniation. This is ossification of the posterior longitudinal ligament, this particular type. Then if you see something like this, remember that it will represent ossification of the ligament. But this is the usual appearance where you got either segmental or continuous ossification of the posterior longitudinal ligament. Next case. Okay, the answer appeared by itself. Then you see here that there is a vertebral lesion associated with extraosseous soft tissue component, both in the prevertebral area as well as inside the spinal canal. Then, if you look to the age of the patient, 7 years, then the possibility of metastasis is not that considered, but you know that Ewing sarcoma is one of the possibilities when you can see affection of the vertebra with extraosseous soft tissue component in the pediatric age group. Next case.
This calcification.
Yes, and this is disc calcification, and here you can see the differential diagnosis of calcified disc. You remember that I mentioned in the degenerative diseases of the spine that the disc to degenerate starts by loss of water, then loss of height, then vacuum phenomena, then the disc will develop later on calcification. Actually, we usually see loss of water, loss of height, and vacuum phenomena, but infrequently we see disc calcification. And here are the causes provided by the literature for calcified disc. Number one, degenerative, sometimes idiopathic, post-operative, post-traumatic, amyloidosis, poliomyelitis, acromegaly, hypervitaminosis D, hyperpara, juvenile idiopathic arthritis, ochronosis, pseudogout, hemochromatosis, ankylosing spondylitis, transient intervertebral disc calcification seen in children. Yeah, you mean that you got some calcium in the disc that resolves spontaneously after some time in the pediatric age group. Next case.
Scar.
Yes, and perineural scarring. You see the evidence of laminar fenestration on the left side, and you got a shadow in the epidural space. After injection of contrast, the shadow enhanced and the nerve root appeared inside the scar. And this is the typical appearance of perineural scarring.
Which fracture?
Yes, and this is compression fracture of L2 vertebra with neural canal compromised. You can see the fixating screws in the vertebra above and in the vertebra below. Next case. This patient had post-traumatic quadriplegia.
So the black fracture
Where?
in the C2, 3, 4, 5, 6,
This
6,
vertebra?
C6. Yes.
Yeah, okay. Then, if you look carefully here, then you can see that this vertebral height is reduced. Also, C5
And
has a
hematoma
reduction in
also.
its height, together with abnormalities in the substance of the cord. And you can feel that the spinal canal is very tight, together with these focal abnormalities, which are most likely due to cord edematous changes secondary to trauma. And the axial images showed the presence of multiple disc lesions that are also adding to more canal compromise. Then, because of the patient had spinal canal stenosis and subjected for trauma, then the effect on the cord was severe, and the patient developed multiple segmental areas of cord edema. Next case.
Birth structure.
No.
TB.
Yes. And the essential finding for the diagnosis of spinal infection is involvement of the disc. And then here you can see that there is affection of the disc with extensive erosive changes in the vertebral bodies. And you may also notice the presence of the some inflammatory granulation tissue anterior to the affected vertebra. It is also evident in the axial image. The next case.
Osteoblastoma.
No, osteoblastoma is a benign lesion with a sclerotic margin and expanding appearance. But this is a destructive lesion in the odontoid process.
Osteosarcoma, chondrosarcoma.
Okay, and this is an odontoid lesion, and this is the differential diagnosis of odontoid lesion. And I should remember you, I should mention once more to look carefully for the region of the odontoid process while evaluating the cervical spine in the plain film, in the CT, and in MRI. These are the lesions that can produce abnormalities at the odontoid level. Inflammatory arthropathy like rheumatoid, you know very well, systemic lupus, crystal arthropathy, meaning gout, calcium pyrophosphate arthropathy, which is the abbreviation is CPPD, is well known to produce abnormalities at the odontoid process, as we will mention in the lecture of polyarthropathy in the musculoskeletal module. Then gout and osteoarthritis, infective arthritis, primary bone tumors, secondary bone tumors, lymphoma, hyperbara, Down syndrome, and Paget disease. Do you see a lesion here?
Odontoid lesion again.
Okay, what do you think? This is T1, T2 contrast.
Metastasis.
This is the axial images.
TB.
Okay, very good. Then if you look carefully here, this is the collection, which is almost marginally enhanced, and there is extension beyond the level of the anterior mass of the first cervical vertebra, meaning that the disc in between has been involved. Next case. This patient had recurrent attacks of unilateral ocular pain with temporary loss of vision, severe symmetric paraplegia.
Neuromyelitis optica.
Very good. And this is, let us say, the appearance together with the history are pointing to the diagnosis of neuromyelitis optica, which is a relapsing autoimmune disease that affects the cord and the optic nerve. And the affection of the cord is usually extensive. They said that it should cover 3 vertebral segments or more. And these patients had positive anti-aquaporin 4 antibody, which is a neuromyelitis optica IgG test, which is positive in about 100% of the patients. The difference between batches of neuromyelitis optica and the MS, that the neuromyelitis optica batches are big, central and extensive, but the MS are small, peripheral, and widely distributed, anterior or peripherally distributed. Also, the neuromyelitis optica can affect any age, but the MS affects the age between 20 and 40 years, and the affection of the optic nerve can be seen if you inject contrast material and you have fat suppressed images. Then affection of the cord is usually extensive, like this one, and the brain patches are not similar to the MS plaques. Next case.
Schwannoma.
Yes, and this is schwannoma in showing the typical appearance with heterogeneous enhancement. Next case.
Aneurysmal bone cyst. Neuroblastoma.
Which one of these?
Aneurysmal
Aneurysmal
bone
bone
cyst.
Yes, and this is aneurysmal bone cyst because of the fluid levels. They are not well demonstrated by CT, but the MRI, of course, is much more better. Next case.
ependymoma.
Now, this is a cystic lesion which is not enhancing. This is not enhancement. Okay, and this is a cystic lesion inside the spinal cord, and I will give you the differential diagnosis of cystic lesions inside the spinal cord. The primary cysts, which represent dilatation of the central spinal canal, are seen in the Chiari malformation, then the Walker, diastematomyelia, hydromyelia congenital, certain skeletal dysplasias, and ependymal cysts. The acquired cysts are either post-traumatic or secondary to tumor like astrocytoma, ependymoma, hemangioblastoma, or inflammatory like arachnoiditis or meningitis, or secondary to subarachnoid hemorrhage. Also, we should remember that any of the lesions occurring anywhere in the spine, or some lesions that occur in the epidural space, in the subdural space, and in the intramedullary space, are the well-known three cystic lesions: the arachnoid cyst, the epidermoid cyst, and the dermoid cyst. And actually, you know that in order to pick up the diagnosis of epidermoid cyst, you should have diffusion weighted images, and the cyst will show diffusion restriction. Next case.
Myelofibrosis.
No, these lesions are bright in the T2 weighted image, meaning that they are not
Myeloma.
sorry.
Multiple myeloma.
Yes, and this is multiple myeloma. If you look to the spine, and then you see that the lesions are not identified in the T1 weighted image, but they are somewhat identified in the T2 weighted image, think of myeloma. But if you see that the lesions are well appreciated in the T1, but not well appreciated in the T2, think of metastasis. If you see that the bone marrow is diffusely black in the T1 and T2 weighted image, think of myelofibrosis. And you know that myeloma is representing 1% of all malignant diseases, 10% of all hematologic diseases, and there are many tests, including the Benz-Jones proteins in urine, to diagnose multiple myeloma. In MRI, the lesions are not usually appreciated in the T1 weighted image, but well appreciated in the T2 weighted image. And the CT scan, you may see only some osteoporotic changes, and this patient had performed multiple levels of vertebroblasty. And this is myelofibrosis. If you look here and you see that the bone marrow is black in the T1 and black, homogeneously black in the T1 and T2 weighted images, diagnostic of myelofibrosis. Next case.
Neurofibroma.
Okay.
Meningioma.
Yes, you are in the differential diagnosis we have mentioned before. Because this lesion is not heterogeneously enhancing, and you can exclude the possibility of neurofibroma somewhat, but because of its intimate relation to the phylum terminal and the conus, you may think of phylum ependymoma. But many times you provide only the differential diagnosis of a meningioma, neurofibroma, schwannoma, and myxopapillary ependymoma. Next case.
Spondylolisthesis.
Yes, this is what we call multi-level spinal instability with multi-level spondylolisthesis. You know that the spondylolisthesis is 4 grades, and starting from grade 2, you know that the bars should be broken. But in grade 1 spondylolisthesis, you should look for degenerative changes or in the facet joints or the broken bars. Next case.
Discitis.
Yes, and this is discitis with epidural abscess collection. The disc is bright in the T2 weighted image, and there is an epidural collection that is marginally enhancing diagnostic of an of an epidural abscess.
Herniation of cephalic
Yes,
migration.
and this is the double fragment sign with herniation and the migration and the sequestration. Next case.
Ependymoma.
No,
Cytoma.
no,
Pharynx.
no. What you see here is an abnormal signal in the substance of the spinal cord, which is relatively swollen, and this signal enhances if you after injection of contrast.
So it is abscess.
No, this is not marginal enhancement. Intramedullary abscess is an extremely rare pathology. This is intramedullary. Okay, forget about enhancement. What do you think of these two images?
Transverse myelitis.
Yes, and this is transverse myelitis. Transverse myelitis can enhance. You know this fact. Transverse myelitis is an abnormal signal in the substance of the cord that can enhance. And transverse myelitis is not a diagnosis, it is a descriptive term for many underlying etiologies like infection, like ADAM, like MS, like neuromyelitis optica. The diagnosis may be reached upon having the clinical history. Then if you look here, this is the focal lesion, which is not appreciated in the T1, but seen in the T2, and it enhances. This localized lesion can fit very good for the possibility of an active MS Blake, which is one of the differential diagnoses of transverse myelitis. Next case.
One more change of 5S1. Fatty change.
Yes, this is T1, T2, and contrast.
Ependymoma.
Yes, And this is an intradural lesion, and we mentioned it many times before, but this lesion was diagnosed by biopsy to be an intradural lymphoma. Actually, lymphoma, the main location is in the epidural space, and sometimes it occurs inside the substance of the cord. But infrequently, lymphoma can occur inside the dura. Then the alternative diagnoses are the ependymoma of the phylum terminal, the neurofibroma, the meningioma, and something like this. But this happens to be an intradural lymphoma. You may consider in the differential diagnosis um, I mean, if you are confronted by a case of an intradural lesion. But the common lesions are meningioma, neurofibroma, schwannoma, metastasis, ependymoma, and paraganglioma. This patient is subjected to a traffic accident followed by quadriparesis.
Victorian enhancement.
Dural venous fistula.
Yes, very good diagnosis actually. And this dural arteriovenous fistula is suspected by these dilated vascular channels along the margins of the cord, and this fistula has resulted in diffuse abnormality or a parenchymal abnormality of the substance of the cord, which may be attributed to edema or ischemia. Then this patient, they failed to close the fistula by intervention. Then surgery was performed, and this is the follow-up after surgery with complete regression of the cord to normal, meaning that the lesion in the cord was just edema, not an ischemia. And the oral arteriovenous fistula is one or considered the most common type of spinal vascular malformations. And these lesions are usually seen in the fifth and sixth decades in males more than in females. There is venous congestion, and the cord will suffer from edema. This will result in progressive pain and lower extremity weakness or sensory changes. What is very important, and even you may remember this if you heard by phone that this patient is suffering from sphincteric dysfunction, then put in your mind that epidural or dural arteriovenous fistula is one of the possibilities, because many times this fistula may be overlooked, or what you are looking for, some disc lesions, some abnormalities in the cord parenchyma, fractures, or something like this, if there is a history of trauma. But this serpiginous low signal or signal void lesions should be carefully interpreted. Then you got lesions of signal void in the subdural space, and you got the changes in the cord parenchyma in the form of patchy increase in the T2 weighted image. Then this is the classic appearance, and you got minute vessels, signal void in the subdural space associated with signal changes in the cord parenchyma. Then we have to differentiate this from the very commonly seen artifacts in the subdural space secondary to CSF vibration artifacts. And many times, especially in the children, where the subdural space is wide, Then you got vibration artifacts within the subdural space. They are quite different from the vascular lesion. The artifacts are not are relatively bulky, and they are not signal void. They can be seen in the T1 and also in the T2 weighted image, but they are clearly identified in the T2 weighted image. Sometimes if you change the pulse sequence, these artifacts will disappear. But many times I see that these patients were mistakenly interpreted as dural vascular malformation, and they are recommended for contrast studies and so on. But this is these are artifacts. Next case. Next case. All candidates go to sleep. Hello.
Lymphoma.
Okay, this is good possibility because of the age of the patient. If you see a destructive lesion in the neural elements associated with epidural soft tissue component in an old patient, then you think of metastasis. But in a pediatric age patient, you think of lymphoma, and this is good. Actually, the best location for lymphoma is in the epidural space. And if you see a lesion like this, which is compressing the cord as well as the CSF and is not associated with destructive changes in the vertebrae, you think of lymphoma. The differential diagnosis of epidural lesions include hemorrhage, abscess, metastasis, arachnoid, epidermoid, dermoid, and the lymphoma. This is T1 and this is T1 post contrast.
Metastasis.
No, metastases do not involve the disc.
Spondylodiscitis.
Yes, and this is a spinal infection with changes in the cord parenchyma. You got here a lesion in the disc, and after contrast injection, you see that there are enhancement of this disc level and this disc level together with enhancement of the dura along the anterior and posterior aspects of the cord. Then you may notice also some changes in the cord parenchyma. Then affection of the disc associated with inflammatory granulation tissue in the epidural space is diagnostic of discitis with changes in the cord of myelopathy. Thank you very much. Walhamdulillahi